and good afternoon, everyone, and welcome to PerfWeb 103, day 4. Is that right? Day 7? Really? Day 7? Man, I'll tell you what goes by quick, doesn't it? Okay, I'm your host, Joe Basha. Contact us at contact@perfusioneducation.com. On the bottom of the screen, you'll see a crawl, a chyron going along down there. That'll pop up throughout the particular throughout the show, and you can reach out to us. Look, at the end of the day, please like us, follow us, ask for notifications, give us the thumbs up. What else do they need to do? Share us, all that stuff. Whatever it is you do on whatever platform you're watching us on, whether it be the YouTubes, the FaceTime, or the X, or LinkedIn, or whatever the heck you call the thing, any of those things, okay? The MediWeb app, go buy it. It's a great app. And I'm really sorry because Jawad Azizi, I'm really upset, Jawad, that you aren't able to get it in your country. Did we ever figure that out, Magic? Magic? Okay, is he gonna be able to get it?
I don't know because I didn't see the answer yet.
Okay, very good. Okay, well, anyway, but with that said, hey, Vicky, how are you? Anyway, with all of that said, try again and see if you can get it. But everybody, get the app, okay? PerfWeb Podcast. You can listen to us on your favorite podcasting resource or platform, Spotify or Podbean or whatever it is. And the app that I talked to you about, you can get from the Apple Store or from the Google Play, either one. So without further ado, we're going to jump right into the program and not spend a whole lot of time on going over our normal opening remarks. But today I'm going to be joined up here at the podium with Vicky Carlisle. She's just arriving. Everybody is busy. Oh, and Tabby is trying to call. Should I put her online or what should I do? Oh, hi, Tabby.
Hi, Joe. Can you just turn on the speakerphone because I cannot hear from my computer.
Okay, David, can you? I don't know what to tell you, Tabby. Hold on a minute, David. I can't handle this, so I don't know what to tell her. No, I understand that. Magic, come take my phone, please. And I don't do the technology. I can only do my part. I'm sorry. Hold on a minute, Tab. We'll get to you. But while they're working on that, I'll talk to everybody. What you might see is I have this, and this is going to be for tomorrow morning's program. We are going to have a lot of fun with this thing. And we're going to have 4 people up here on the stage. They're each going to have their own eraser board. We're going to go over board questions, ABCP board questions, some multiple choice, some fill in the blank. And whenever somebody gets it wrong, then they will have to roll the dice. And when they die, and that number represents how many times this has to be clicked into the patient until the patient explodes, meaning the patient has passed. And with that said, when that happens, then they get a point. And there's 3 rounds. Round 1 is going to be 1 point each. Round 2 will be 5 points each. Round 3, 10 points each. And one final question, which is going to be worth 50 points. So you could be in last place and end up in first place, depending on the situation. So we're really looking forward to that. Okay. David, we need to move on to something else if we can, if you can help me out. I mean, I don't know what else to say. I'm sort of done talking. Can we take a 5-minute break? So we're having some technical difficulties. So I'll go that route. Okay. So if you could give us 5 minutes and reconnect after 5 minutes, or just stay online, whatever you prefer to do. I don't think we have to turn everything off, but they need 5 minutes to figure out the technical problem. Thanks. I'll be right back with you. Okay.
Can you say something?
Yes, did you hear me?
Let's go live. Okay, hey everybody, I've got Vicky Carlisle with me, and I have super porn Google Meet. This is going to be very challenging. I can't do this. Gabby, this isn't going to work because I hear myself through your computer. You'll
Oh.
have to put headphones on.
Oh, okay, hold on. Yes, no problem. I can
It
do
took,
that.
it took,
Okay, hold on. I'll put my phone on.
I would think that the technology people would have figured that out. Do you want your headsets? He does. She doesn't. That's over there.
Better? Yeah, perfect.
I mean, we're falling apart. It was great. All right, there. All right, perfect. So I'm here with Superborn Kupolny, who is a PhD in physiology and who trained under the incredible Dr. Navar. I think Dr. Navar is actually watching the program. So hello, Dr. Navar, if you're there. I want to say hello to you and hope to see you again very soon. But for those of you who don't know Dr. Navarre, he's former chairman of the Department of Physiology at Tulane and trained directly under Dr. Guyton, and that's saying quite a bit when you consider who Dr. Guyton is and Guyton's physiology. So very, very well trained physiologist, and put out an incredible student in Superporn. Now, she goes by Tabby, and Tabby is from Thailand. She is a graduate of the Thammasat, I think I said that right, Thammasat University, and you trained there as a perfusionist, worked there as a perfusionist, and were a perfusion educator also at that university, and continue to be to this day from what I understand. But you're also in perfusion school at the SUNY University up in Syracuse, New York, State University of New York, and it sounds to me like you're doing an incredibly good job up there. You've done some incredible simulations, and you're going to be coming down here to Houston with us to be on a clinical rotation. We're working on that. I've got a meeting this Thursday about that very thing, and we're going to be getting all of this situated for you. And then you're going to be working here for us so that I can finally quit and retire. Well, you know, it's not my job to turn on the microphone. I mean, I've done everything I can do today. I've done everything I can do. You're killing, I'm killing you. I'm fixing to get a rope. You'd get one for me. Thank you. Yes. So I'm hoping everybody out there heard everything that I said, but probably did because my voice is so loud, but it's probably sounding a lot better now. So they've had to turn the sound down finally. With that said, Tabby, there is a confounding issue in perfusion. It is something that has been a problem for us for a very long time and continues to be, and that is that there are people, and there's been published papers on the use of ultrafiltration during, we can hear you, audio quality is perfect. Thank you so much, Peter. All of that is the work of both David and Magic. I had nothing to do with it. But with that said, there's this controversy about autotransfusion causing renal failure, and it's a real problem because we are seeing in some places that believe that more and more both hemodilution and anemia post-cardiac surgery, and also a tremendous amount of blood post-surgery, the post-bypass that is being processed in the cell saver, which I think carries its own very serious complications. With that said, being that you do hold a PhD in physiology, being that your primary focus, of which you have actually won awards for in international physiology meetings, people can look up your CV on our website, on the Perfusion Education website, and see all of your CV and see all of your publications and research and awards that you have accomplished and been awarded. But your field of focus or study is actually renal physiology. That's what you're very much involved with. So I would consider you to be an expert in renal physiology and renal this particular subject. I think you're going to be the person who can answer the question because it is a complex one. And unless you understand cardiopulmonary bypass the way we do, where you have an open system and a reservoir and all of the things that happen, it is not a normal physiology anymore. And so we're taking a patient with essentially normal physiology, creating a very abnormal circumstance for them with bypass, and then we're reestablishing their normal physiology when we wean from bypass. And certainly we do still see a not insignificant amount of acute kidney injury, and the range is anywhere from 5 to 7%, as high as 25%, depending on what study you're reading and how it's being measured. But for those who go on with acute renal failure requiring new dialysis, that number is much, much lower, but still it is, in my view, unacceptably high. And I think there's another reason for it, but ultrafiltration is being blamed for it, and I think that is going to go on to exacerbate what is already a serious problem. That's my view. I think everybody is well aware of how I feel about this, so I'm going to stop talking and let the expert tell us what's going on here. So with that said, Tabby.
Thank you, Joe, and thank you so much for the invitation. It's an honor introduction. I mean, that's great. Thank you so much. Let me share my screen. And also, I think that this topic, that's my journey. I would also want to share why I keep learning and learning physiology. If everything go well, you see my screen right now? Did you see my screen?
Yes, we do.
Okay, that's great. Let me move a little bit. All right. Just briefly about me and why I was a perfusionist at your introduction. I was a perfusionist in Thailand for 8 year experience. And that's a long time ago when I just started as a perfusionist. I have a case. She's skinny, but like the aortic valve regurgitation have come to the hospital for operating for do the AVR. The body weight is, I think, maybe about 40 kilograms, just skinny, and she's a woman. But with the AR, it's kind of high CVP, big heart. And when I start the CPB, I'll drain, too much drain it, and the level, the reservoir is just going up, and down. I'll try to drain it out to the back. And eventually I think how I can do that. And she, too much hemodilution, anemia since the beginning. And then I'll start to do the ultrafiltration. I'll do cuff, the whole case, about I think I got the volume maybe 2.5 liters, something like that. And when I come off the bypass, it's good. I mean, keeping up for the hematocrit, and I can maintain everything is well during my case. And that sparked my idea. I was kind of interesting in ultrafiltration. And I was kind of thinking more and more, just thinking about the kidney at that time. That's like a young perfusionist, and what's going on for the kidney. But just keep in my mind, just on myself. And until compete for 8 years for experience, I said, how about I'll go for learn more, just want to learn more about the physiology, and specifically kind of interest in renal physiology. And like it just keep going on and on. Eventually I got the privilege, I think, I would say the privilege opportunity. I was complete my postdoc under the supervision Dr. Gabriel Navar. As Joe introduction, he was the past chair of the American Physiology Society, and he's a like a kidney person, role models. And when I'll start in the lab, when I work in the lab, he has a nice techniques. We call the Jata Komolula Nephron technique, which I can see like the renal afferent arterial, and specifically to research for the kidney hemodynamic. And I will show more for my study. And that's my journey in perfusion, and also for physiology, and also for the ultrafiltration. That's how I'm excited to talk about the ultrafiltration for today. For my talk today, I will start by the basic physiology, so a little bit, but kind of focus for the perfusionist, and also we show some data about the ultrafiltration and how it affects the kidney, and how we can improve, and how is the outcome. That's the whole idea for my talk today. And I'll start by the slide that's from my mentor, Dr. Nora. It's a simple slide, but it's great. Just when we look at this slide, what is telling us? 20% from cardiac output, the blood go to the kidney. What does it mean? 20%, I would not say a few, but that's a lot. That's a lot. Kidney, it is not only functions for the just not for the electrolyte balance, but that means a pass amount 20% of blood at the kidney. So that means it's also control the, like the volume and also for our blood pressure. That is the kidney job. And I'll show you more for the structure. Well, inside the kidney is kind of the complex structure, but one of the most important is here that we call the renal afferent arteriole, which is control but go into the port inside the kidney, inside the nephron. Here is important. You could not go too low or you could not go too high for the pressure. We need the range of the pressure to keep renal blood flow stable. And then we have for the filtration, they have the range that we call the renal autoregulation. The range is just about 60 to 160 millimeter mercury. This is a good range. What does it mean? What it's telling us? Kidney is good. I would emphasize here. Kidney is good for pressure and for the flow. Pressure and the flow. It is not for the hypoxia, like a low oxygen, high oxygen. That would not that much for the kidney. Kidney control for the flow and for the pressure. For what? To control the 20% of cardiac output. This is their job. But go to the kidney. It is, as I mentioned, it's just not only for the filtration, but that's kind of maintain the blood pressure also. And a part of blood go to the kidney. That's to supply for the kidney itself, to the kind of the kidney tissue. But as I mentioned, kidney is good for the pressure and for the flow. If you kind of low blood flow, if you low pressure, that's directly effect on the kidney. That's what's the most important message that I want to emphasize right now. And think about when we do the cardiopulmonary bypass, in case you like a hypoperfusion to the kidney. So that's direct impact for the kidney. And I'll go to next. I want you, that's apart from our study, I mean from Dr. Nawal's. This is the renal afferent arterial diameter. And as you can see, when we increase the pressure, when we increase the renal afferent arterial pressure, you can see the diameter kind of go down and down. That's kind of more constriction. That's why how to control the keep the constant blood flow to the kidney. That's the kidney job. And I would like to show that's a part of my study. Not sure as you can see, I hope you can see it. Just keep eye on here, let me show you. This is the renal afferent arterial. We do under the microscope and kind of, okay, let me show you again. This is the renal afferent arterial. You see the diameter is right here. And when you increase pressure, and you can see its movement. It's just a second, and then you can see the vascular movement to control the blood flow. And we published in 2020. Yeah, that's we published. That's I want you to see. And you can see it's kind of movement, just very quick to kind of regulate the renal. And what the message, that's what kind of important. You see as I mentioned, the flow and the pressure, that's important for the kidney. And inside the kidney, inside itself, kidney have two layers, the cortex and medulla. And in the medulla, whereas outer medulla and inner medulla, you can see the oxygen tension at the inner medulla, it's just 7%. It's kind of low oxygen tension in the inner medulla of the kidney. That's message. What is that telling us? It's telling us kidney susceptible to hypoxia by the structure by itself, as you can see from the structure right now. And if we think all the organs do they tolerant for the anemia? Do they behave in the same way? From the study, but that's from the animal study, and you can see that they compare the heart, intestine, and the kidney. And then they start to start the hemodilution from 25% to 15% to 10 and 5%. Kidney is rapidly decreased tolerance for the anemia when you compare to the heart and you compare to the intestine. So that's suggesting that kidney is less tolerant for anemia. That's the the basic for the physiology. That's how I want to emphasize everyone to. That's will link why we need to control the volume when we do the ultrafiltration, but I'll present for the next. And we do the hypothermia. When we do the bypass, we do the hypothermia techniques. In each organ, respond to the temperature, just a bit different. And then again, that's from the animal study, and you can see for the kidney is it's like identical for, when we do the hypothermia and when we measure the arterial line for the temperature. Kidney is cortical for the temperature that we see from the arterial. But the important and exciting to see is that when we start to bypass and then we cool down, even high flow or even low flow, it happened to the blood, it shunt, but go to the body, but it shunt to the muscle. But for the kidney, and you can see blow blood to the kidney during the bypass. And when we reform, kidney is one of the organs that's increase the metabolism and is increased rapidly. So what does it mean? What it's telling us? It's telling us from the study that show us for the flow, for the pressure, and also for the rewarming phase, we need to really to control for the oxygen, because it's high oxygen consumption. Because during the bypass is low, but go to the kidney. That is happen. And also the structure in the kidney, as you can see, kidney have the shunt inside the nephron, the shunt. So in this side, that's susceptible to hypoxia, as I mentioned. All together, this is one of the a good publication, and to bring us to more understandable why kidney is susceptible to hypoxia by the structure and physiology, basic physiology and the structure by kidney itself. 7 reasons that's why kidney is susceptible to hypoxia. As I mentioned, one of the important things, as I mentioned, is they have the shunt and also low medullary blood flow, low oxygen tension, and that's what we need to think about. And next, I want to show you for the study. That's why from the study that's bring up to do the goal-directed perfusion. The study compare when we control the bypass of our conventional, just keep for the cardiac index, and then we do the conventional. And then if compared to the goal-directed perfusion, if we do the bypass and keep the DO2 to over 280, 270 or 280. If we control for the DO2 bypass and also control for the DO2 over 280, it's almost a half. That's to prevent the AKI state 1 compared to the conventional techniques. That's emphasized during the bypass. We need to control the pressure, we need to control the flow, and also for the oxygen delivery. That's one of the important factors to prevent the kidney. And again, from this study also show even when we measure the DO2 during the bypass, that means the systemic DO2. We see the systemic DO2. Even you have the high DO2 for the systemic, but the DO2 to the renal DO2 during the bypass is decreased. Even you high the DO2 for the systemic. That's why they emphasize from the study, you kind of to maintain the DO2 at least more than greater than 280. That would be helpful for the kidney. And again, this study shows us again, it's kind of increased oxygen extraction during we do the bypass. So I'll go to kind of the simple formula, but that's emphasized and it's important to mention again. DO2 is depend on the blood flow from our flow during we do the bypass when we control the flow, and also for the oxygen content. Oxygen content mostly depend on your hematocrit oxygen saturation. So that's the important factor. And I'll go to the ultrafiltration. Why less the kind of why have the data show why this effect for the renal failure, why it's effect for the kidney when we do the ultrafiltration. As Joe mentioned, as Joe talking about, they have the publication to show us in this way. Before I go to that, let me show that's important. During we do the bypass, I think to control the volume, the blood volume, that's the goal. That's very important. And that's the study show perioperative weight gain during the operation. During perioperative, if the weight gain greater 20%, the mortality rate is 100%.
That's not that much.
But when I saw this study, I was like, wow, we really need to maintain, to control the blood volume during we do the bypass or any kind of operation. And that's me thinking about the case that I'll talking when I'm thinking about the case, this kind of volume overload, and we need to maintain the volume. That's important. And several studies, I would say a bunch of studies show the ultrafiltration, even mouth, cough, ultrafiltration during we do the CPB. It showed the benefit. They show the benefit for our body. It's reduce the edema. And also, you reduce the edema is you improve. That means you improve the tissue oxygenation. Let me show you for the data. For this data, what did it show? Compare between during the bypass, the group do carb and no carb. And as you can see, the group do carb. You compare for the last bypass, when we end of the bypass, it increased the hematocrit. That's significantly increasing the hematocrit. That's good. Yeah, increase the hematocrit. That means it's ready to increase the DO2 if you control in a good flow. That shows the benefit to the body. And then when they compare to see the creatinine clearance in the group that do carb, it's have a benefit for help reduce the creatinine clearance for the body. That's kind of benefit for the kidney. That's from the study. As I mentioned, there's a bunch of the study from kind of the whole time during for the perfusion community, and we know that that's showed for the benefit. I'll show you more. This confirm again for the volume when we do ultrafiltration during the CPB, less than 1 liter, 1 liter to 1.5, 1.5 to 2.4, and greater than 2.4. When you finish for the bypass, the higher you remove the volume, that gives the benefit for your kind of increase the hematocrit. Again, you increase the hematocrit. That's a benefit for the kidney, as I mentioned, because kidney is susceptible to hypoxia by itself. You increase the hematocrit, you increase the DO2, and kind of prevent for the AKI at the study. That's I'll show you. That's the study that showed before. But the one that we need to be concerned, that's from the same study. However, if you have too much volume for the ultrafiltration, it's kind of it correlated to, for decrease the urine output. That's one point that we need to be concerned, kind of to balance. And I would agree for that. But the question is how much is too much? How much is too much? And how about the lead? I think that's the question that we need we need a good answer. How we can control the ultrafiltration for lead? What is the optimized that we should be control? I think that's the most important, and we need the answer. But let me show you from the study and kind of popular one. And they show do the ultrafiltration is related to it. It's kind of increase the risk for post-operative AKI from the study. Actually, when we look at more and more in the detail of the study, yes, ultrafiltration from the result from the study, ultrafiltration is increase the risk for post-operative AKI. But because of at the volume greater than 32 cc per kilogram, right there, if you do the ultrafiltration at the weight in the cup greater than 32 cc per kilogram, that's increased the risk for post-operative AKI. But it didn't show for lower than 32. That's I mentioned, and that's my point of view. I think the important is depend on the pressure on the floor and how you for the lead that you do the ultrafiltration. If you increase the higher lead, it's made susceptible, it's may cause for the hypoperfusion to the kidney. I was thinking ultrafiltration, the technique, the principle, it is not a problem, but we need to fix the lead to prevent the hypoperfusion, because you too much the lead, that you may susceptible to do the hypoperfusion to the kidney. If you hypoperfusion to the kidney, as I show you, kidney is regulated by the flow and the pressure. That's the important. And again, the publication in this year 2025 just published, it show again ultrafiltration increase the risk for AKI. But in the detail from this study, when you do the ultrafiltration, the weight index greater than 30 cc per kilogram, I think it depends the lead. It depends the lead of the ultrafiltration. I would say again, the principle of ultrafiltration is not a problem, but we need to control the lead to prevent the hypoperfusion to the kidney. I think that's the rationale in physiology, that in my point of view. I was thinking just a little bit more deeper. We also, during the bypass, this is from the animal study, but from the animal study to the bypass, they show that it's increased the inflammatory cytokine, specifically for interleukin-6, as you can see during the CPB. It's increased for the interleukin-6, which is a kind of cause for the inflammation, and kind of too high increase is more than 4,000-fold compared to the baseline. And as we know, there's inflammation kind of one of the cause for the kidney damage. And I found a study, if you do the ultrafiltration, but the study, that's a long time ago, but that's great, that's sure for the ultrafiltration. It also can decrease the inflammatory cytokine, the TNF alpha, interleukin-6, interleukin-8, as you can see after the ultrafiltration. This kind of decrease the inflammatory cytokines. That's great to kind of prevent the inflammation. That's also benefit for the ultrafiltration also. And here, as Suni, Hani, and the group of Hani do the big study, the systematic review and meta-analysis. And the study includes so many studies and do the meta-analysis. And they show ultrafiltration in cardiac surgery is not as, let me see that. It's not associated with the increased AKI, and also it showed the benefit for the patients have the kind of the underlying of chronic kidney injury, have the benefit also for do the interfiltration from the meta-analysis from this study. And recent guideline, actually 2024 EACTS, the recent guideline, but that's published this year, published in 2025. It's just published, kind of the most recent. Also recommendation, the recommendation in class 1 level A. This is the strong evidence support, right, to show for the class 1 level A. It is recommended to use MAP or CARB combined with MAP at high risk or anemia patient to reduce chest tube bleeding and blood transfusion. That's from the updated guideline. I just published a review article, with my group from Vanderbilt and also with my mentor, Dr. Navar, and also from my perfusionist friend. What we're talking about in the review article that's published, published last year. Important factor affect the kidney is on the pressure and force. We need to avoid the hypoperfusion when you do MAP, do CAP, do ultrafiltration. The rate is important. Not too much for the rate, but as I mentioned, how much is too much? I don't think we still have a good answer, but Joe may can have the answer for his clinical practice. Avoid the hypoperfusion. I think that's the most important. Avoid hemodilution. That's also important. How to avoid hemodilution to prevent the AKI, to prevent the kidney damage. Ultrafiltration help you, definitely. Ultrafiltration help you to avoid hemodilution. And for my review article, actually we talking about the sex difference between male and female who susceptible to AKI, how different between the sex. I want to kind of input more information. For the female, for women, women lower hematocrit compared to men. That's ultrafiltration also helpful, I think, that's for in women group. That's kind of to avoid the hemodilution. That's one also for the benefit. From my point of view, if you ask me about the ultrafiltration, I would say I'll support for the ultrafiltration as a physiology that I was showing you from my point of view. And I think the most important, you need the oxygen. You need a good oxygen delivery to the kidney. You need a good flow. You need a good pressure. That's the important. Again, ultrafiltration, I think the principle is not a problem, but we need to kind of target the flow rate when we do the ultrafiltration to avoid the hypoperfusion. I think that's the benefit that we should be concerned. And so that's it from me. So thank you, Joe. Thank you so much.
That's a big dog.
That is a big dog, Tabby.
That's a big dog.
That is a very big dog. Yes,
It's bigger
very
than
big
you.
dog. And I like your hemoconcentrator. It's a smaller one, but I'm glad that you have that in there. So it sounds to me like we have you got some thank yous online from I believe that's Nancy Falk, if I remember correct. Nancy, I believe. Yep. And welcome everyone. So it sounds like it's still controversial, and I mean, it's almost which study do you want to believe? And because you did show some studies there that supported the idea that ultrafiltration is a cause of AKI, and of course, they pointed out that if it's greater than 32 milliliters per kilogram, so for somebody like me, that would be 3,200 cc's. But 3,200 cc's of my baseline volume, 3,200 cc's of my baseline volume plus a liter of Del Nido and the 1,500 of prime for the pump and the inevitable amount of irrigation and pour cold that gets sucked into the pump. You know, what 3,200 are we talking about? Or is it just 3,200 blanket? How are we controlling for so many of these confounding factors? And if you're saying that by using ultrafiltration, you're lowering your volume in your reservoir, therefore you're having to reduce your blood flow and maybe blood pressure, how are we using these other factors to correlating these so that we're adjusting for them, right? What is the perfusion technique? Are they using, not that I think pulsatile flow works, but in a heart-lung machine, I don't think you can really generate a pulse that's anywhere close to being physiologic. I think you do more harm than good. But regardless, are they using a lot of suction blood? Are they what are their mean pressures? Are they between 50 and 70, between 70 and 90? What is a normal mean arterial blood pressure? Well, for somebody with a little bit of hypertension, it might be 100 or 105. Is their normal mean pressure? But we're running mean pressures of 50 or 60 all day, and then you're saying that it's ultrafiltration. What is it? Is it not the pressure? Because I think you did say, and I do think that that the normal physiology textbooks support that a mean arterial pressure of 50 is not good for the kidneys, especially if you're chronically hypertensive. But you could correct me if I'm wrong on that. So there's all of these factors, and I don't know what if you could really take them all into consideration, control for all of them, and say, we can now point our finger to this as the cause when we don't know what all these other things may have done. In fact, we do know what they all do, but are we really considering them? Are we factoring them into the study? And that, I think, is part of the problem with some of the research that I've seen, is that it doesn't take all of these factors into consideration. What say you?
Yeah, I see what are you saying. Let me kind of the whole idea for depict to answer your question. Flow and the pressure, that's important for the kidney. You do the ultrafiltration, no matter what how much you do, you need to keep, if you kind of too much for your flow rate for ultrafiltration, you need to maintain your flow. You increase the flow because the kidney have the auto-regulation rate 60 to 160. From our textbook for the perfusion and for the guideline right now, they suggest to maintain about the 70, 60 to 80. That's the most important one. You keep the mean arterial pressure. And from the study, I think it would be great if we can see for the factor for the blood pressure, because now we see the volume, but we didn't see the blood pressure. The blood pressure is important. If you maintain the flow, you maintain the good pressure to the kidney, and in the range that kidney can do, that is work well for the kidney to protect the kidney. One, this is the most important factor. Second, oxygen to the kidney is important. When you do that, that's why I said I support the ultrafiltration with the important reason, because it increase hematocrit. That's why increase the oxygen delivery to the kidney. But I emphasize again, you need to keep and maintain the flow during you do the ultrafiltration. And I don't know the answer for now. That's why I ask how we can, for the flow rate to the ultrafiltration, we still under the question, what is the optimal, what is the proper flow rate that we should do. Now that we don't have the question for the flow rate, I think keep the blood pressure during you do the ultrafiltration and keep that's help you for increase the hematocrit. That would benefit. That is the benefit for the ultrafiltration. And that's why I said I support to do the ultrafiltration. But I didn't say just do the ultrafiltration. I say you do the ultrafiltration by maintaining, keep the arterial pressure. That's for the auto-regulation. That's my answer.
Okay, so the other thing I want to add to that, if I may, because I have a question here from Nancy, and just so you know, Peter Foster says you did an incredible job. So he was very pleased. We were very pleased too. But I want to throw this out at you, since we're talking about pressure, is how you can manufacture a pressure. So if we have let's say a hemoglobin of 6, hemoglobin of 6, a crit of 18, there's places that won't transfuse. And so you can try to flow as much as you can. I mean, you may be able to flow more, but you can't overflow your venous drainage, or that becomes a separate problem. And that's a limitation, because the venous drainage is never going to be able to accommodate even the heart-lung machine. The oxygenator can't accommodate an 8 or 9 liter blood flow. Most of these are limited to about 6 to 7 liters of blood flow for their effectiveness. But how much does dilution itself in decreasing, even if you could flow enough, just the mere fact that you generate a pressure through artificial mechanisms vis-a-vis norepi or phenylephrine or whatever you're going to use to get the vasopress and to get the blood pressure up, but really it's low, not just because you don't have flow and vasodilatation, but it's low because your blood viscosity is so incredibly dilute. How much does that factor into all of this?
Can you ask me one more time? You said we are in the condition that's low hematocrit, right? For example,
Yes,
at
so-
6,
right,
but you
so-
cannot increase the 4 because you're
Let's hypothetically say you could increase the flow to 6.5 liters. So you're flowing 4 liters, and that's the calculated flow at 2.4. But in order to get even close to 280 milliliters per of an index, 280 milliliters meter squared for your O2 delivery, your DO2, you have to flow 6.5 or 7 liters. But your blood viscosity is very low, and so that's going to affect your mean arterial pressure, and now you're having to use phenylephrine or some other vasopressor in order to give yourself a blood pressure above 60. How much does that hemodilution, that loss of viscosity, affect the renal perfusion, because you're artificially raising the pressure versus the pressure being where it is because of normal vasomotor tone?
Okay. Your question is, pressure is not a problem right now. You can increase the 4, you can give the medication, right? But the problem right now, the situation, low hematocrit, kind of low 18. So that means also low viscosity. When you do the flow is kind of rapid. Yeah, you may have a good blood pressure, but because you increase the high flow, you don't have that much time for the diffusion. They also, we need a transit time. You just not the pressure, but
so
you
the
also need the
transit
time.
The transient time or transit time through the capillaries is going to be too short.
Yeah, you need transit time, one problem, and another problem because you low hematocrit right now. That's 2 factors that's cause the kidney problem also in this situation.
So I have another question for you. This is from Nancy. And what happens when you throw mannitol into the mix of pressure and flow, hemoglobin, and ultrafiltration? So when you're adding mannitol, and you should be able to see the question up on the screen.
Yeah, I see, for the mannitol.
Yes. How does mannitol basically affect our kidney perfusion, whether it be protective, whether an osmotic diuretic is beneficial? Do you get crystals in your tubules during hypothermia if you use mannitol? I'm not a big mannitol user, but a lot of people I know are. They really believe in it, and they give it empirically on every single case. I don't like it, but I did have use for maybe scavenging oxygen radicals years and years ago, but I don't know if it really worked. We just believed it did. So it's kind of like DDAVP and platelet function. We think it helps, but I don't know there's any evidence to support it, but we still do it.
The question is, you mix mannitol with cup, high pressure, high flow, right? The question. I kind of try to understand the question.
They're saying mixing mannitol with pressure, flow, hemoglobin, and ultrafiltration, and still using mannitol. So it looks like you're doing these things. You're keeping your pressure up. You're using good flow, hemoglobin. You're using ultrafiltration, but you're also adding mannitol to the mix. Independently, is mannitol beneficial?
But that's our practice in Thailand. We do the mannitol in every case. Okay, let me answer the first question. I answer with the data evidence for the recent guideline. They didn't, how we can say, they didn't show the benefit of mannitol. If you think mannitol to protect the kidney, to prevent the AKI, that not show no benefit for mannitol to prevent the AKI. But from the physiology, from me, and what I'm thinking, you add the mannitol, the mannitol is osmotic diuretic. So that's, if volume overload, mannitol help, right? You more diuretic. That's help to kind of lower for reduce the body volume. It's help in this way. But if it's helpful to prevent AKI, from the evidence base, no data suggests to prevent AKI. But if you want to do too much volume, as my case, the CPB 14, 15, 16, and kind of anemia, you do the mannitol, you do the cup, that's kind of help you to kind of reduce the volume. But again, you need to make sure that you increase the flow, you compensate the flow, and you keep the blood pressure in a good direction.
Mm-hmm. Now, let me ask you this, if I may, as well. It'll be the last question because I'm going to get in trouble, but Nancy does mention that many institutions utilize mannitol in the prime, and that is true. And I used to all of the time, but I want to kind of get away from that for just a moment. I do think it has a benefit for reducing intracellular volume, right? Because you will pull volume out of the intracellular compartment and probably also the interstitial if you get the osmotic pressure high enough, but that's very transient because mannitol is used for closed head injuries all of the time, neuro, right? For that reason, to decrease intracranial pressure. But one of the things that is concerning to me is that we don't measure the oncotic pressure, used to be referred to as the colloid oncotic pressure. I realize that's redundant, but COP, and that hypoalbuminemia is a very big problem. So we look at the hematocrit and we see the hematocrit is very, very low, but we never think to ourselves, well, the hematocrit's low, so is the albumin level probably low. So a lot of the fluid that we are removing with ultrafiltration is concentrating the intravascular space and thereby increasing the oncotic pressure to bring back a lot of fluid from the interstitial space so that we can then continue to ultrafiltrate it off. Because would it not be true, and you can answer this yes or no, would it not be true that if we have third spaced a tremendous amount of volume into our interstitial space and tissues, that the kidneys would also be edematous in the parenchyma of the kidney itself and decrease its perfusion by virtue of having essentially obstruction? You'd have almost compartment syndrome type of scenario. Is that true, or do you feel differently?
I agree in some part that you mentioned, but during the bypass, but still don't know how long. But for the bypass or even ECMO, the shear state, the inflammation when contact the artificial surface, that's caused the kind of damage, the glycocalyx. The glycocalyx is kind of the level that's cover the endothelium.
Sure.
I don't have enough data to address. I mean, I agree with you for some part, but I just want to add more information. In case of the glycocalyc preserve. You may right, I agree. But if glycocalyc damage, your albumin leak from the glycocalyc, that would not true that you said. It
Yes, I
depends.
do agree. So if you have what I would call capillary leak syndrome, you have a damaged glycocalyx and you have true capillary leak syndrome and you have albumin leaking out into the interstitium, giving any more albumin would only exacerbate that problem. However, in the absence of that, which I only think really happens in extreme inflammatory processes, and it may happen some on bypass, but we don't know to what degree. I think minimal in most circumstances. But let's just assume an intact glycocalyx. In that case, I feel very strongly that albumin is very beneficial and that we should not allow it to become so incredibly low, and that it itself is a potential cause of AKI. That's my theory.
I would say I agree, and yeah, albumin is important to hold the volume. I mean, increase the oncotic pressure, and when I
Okay,
would agree. In the preserved glycocalyc, I need to emphasize that in the
Yes.
preserved glycocalyc, yes.
I think that's fair. I think that's a fair statement. So if you'd like to stay online, you're welcome to if you'd like to, and we can listen to Vicky's lecture today on the cardiac cycle and intra-aortic balloon pump timing. It's something that a lot of perfusionists do not know enough about. I'm seeing more and more perfusionists coming out of perfusion school that have never even touched a balloon pump and have no idea what it's actually doing, which is concerning to me because it's such a commonly used device these days. And I think that we need to get better at it. So you're welcome to stay if you'd like and participate in the question and answer after hers, or if you need to go, because I know it's an hour later for you there and you probably have class early in the morning, you can do that and we certainly understand it. But thank you so very much. You have a lot of comments. Everyone loved this, and I can't wait till you get back here. I'm looking forward to it. I got to come back up and see you again operating that simulator.
Thank you so much, and thank you,
Thank you,
everyone.
Tabby.
Thank you so much.
Thank you.
Bye bye,
Thank you.
Tabby. And
Bye.
one day we're gonna do a program and tell the story of how we met. I think
That's
that'll be
incredible.
a very fun presentation. I think it's my goal to continue with the international outreach and to continue to grow my community of colleagues and friends on a global level. And I think that's how we're all going to get better at what we do. So thank you so much for doing this.
No, you're welcome. Thank you so much. Thank you, everyone. Thank you. Bye-bye. Bye.
Thank you, Tabby. And thank you,
Tabby.
Dr. Navar. Good luck. We'll see you again soon, I hope. Okay, so now, cardiac cycle, balloon pump timing. You're on.
Okay.
Vicky Carlisle. I think everybody here knows Vicky Carlisle. She has become the absolute, you know what? You're going to have your own show.
Oh, Lord.
You are going to have your own show. You do this so much, you actually are beginning to like it. I'm convinced. Convinced.
Well, I did come early, so.
Yeah, you did. I'm very proud of you. Okay. All right, let's roll.
Okay, so yeah, today I'm going to be talking about cardiac cycle, primarily in the beginning and move into balloon pump timing. And as always, I like to start off with a little history to kind of give light onto the things that transpired to get us to where we are now, kind of highlight the individuals who've made progress in medicine and biology, where we're at possible, and who moved this knowledge forward for us. William Harvey, of course, is the first person to correctly describe the cardiac cycle and the flow of blood way back in 1517.
The second oxygenator I ever used was a Harvey oxygenator.
Was
That
it really?
Yes, they don't exist anymore.
From
but-
this Harvey?
well,
Or
not
named
from
after
him
him?
personally. No, he was a little bit before my time, but the name of the company was called Harvey.
I see.
It was the Harvey H700 was the name of the oxygenator. Sorry.
That's okay. With many things in medicine, it took contributions from many people in many different eras to kind of get everything together. But our knowledge on the circulation of the blood in the body is one of the few advances in medicine that can kind of single handedly be attributed to one man, that being William Harvey. He graduated from Cambridge University 1597 and then moved on to the University of Padua in northern Italy, one of the most prestigious colleges around during that time, so much so that Copernicus studied there. And Galileo was a teacher at this university while Harvey was there at the same time. So, of course, he graduated in 1602, returned to England, and he became like the physician extraordinary to the king, two kings actually, for King James I, and then after he passed, he was also for Charles I. But at any rate, 1628, he published De Motu Cordis, which I always have trouble saying it. That's like the real shortened version of this book. The whole title is over here, which translates into the studies of blood through the living animal, basically, is what it is. So we shortened it. But here he is the first to describe systole and diastole, the first to explain where the pulse comes from, how it's generated. He explained the heart valves. He was the first person to actually use measurements in studies of physiology, which is probably one of his most important contributions. And of course, he estimated the first stroke volume. Of course, many physicians at the time kind of thought that blood was made in the liver, sent out and consumed completely by the body. He just did simple math to show that that wasn't possible and kind of kicked him off kind of to shorten this experiments here. But the body would have to produce, 540 pounds or so of blood constantly in order to do this. So it made no sense to him, and that's how he came up with it. He did look at the volumes in the heart, and he estimated that 2 ounces of blood for every 60 heartbeats per minute averaged out. And he came out pretty close to what our stroke volume is now, approximately 60 to 70 for an average stroke volume. So he was pretty close. Fascinating guy. And then the other part of understanding all of this, of course, is the electrical system, which took the contributions of many folks. Leonardo da Vinci in 1510 wrote that the heart was self-moving. Harvey, of course, we just talked about him. He noted that motion and contraction in the heart muscle started in the auricles, which auricles kind of sit over top of the atrium. It's like that cauliflower little area right here. It's kind of like a muscular outpouching that can kind of help hold more volume if needed. Purkinje, he found a pale muscular cell in the ventricles. Of course, the Purkinje fibers, that was in 1839. His, in 1893, showed a muscle bundle that connected the atrium to the ventricular septum. Tawara, he found the node in the atrial organ in the top of the bundle of His. And then, of course, Keith and Flack, these guys up here, gave us the SA, the fibers at the SA junction. So that's your pacemaker of the heart. And these are just showing the electrical fibers here, going through Purkinje down into all the different muscle sections of the heart. It's like the left bundle branch, the main division's coming down there. It's injected with India ink to kind of make it look blue, so that's why it highlights. And these were Tawara's drawings of the same thing. Okay. We can't talk about cardiac cycle without going into the Wiggers diagram, of course, developed by Carl Wiggers. 1915 was where it first showed up. It is important to show us the pressure changes, volume changes, heart sounds, and EKG. These are all the components. At one time, it did have peripheral pulse pressures on there as well, but that's since left off most of the time. And sometimes you can get your atrial in here as well, as far as that goes, but This is the one that we use mostly now. Key concepts that we take from this is going to be our cardiac cycle phases. So it effectively illustrates the different phases of the cardiac cycle, including atrial systole, ventricular systole. You have your isovolumetric contraction and relaxation. We're going to go into all of these here in just a minute. It also shows pressure-driven blood flow. So it highlights the principle that blood flow is driven by pressure, gradients within the heart. Valves open when pressure in one chamber preceding the valve exceeds the pressure in the subsequent chamber. It also depicts your valve function, so how the opening and closing of the heart valves regulate blood flow and generate the characteristic of the heart sounds themselves, the lub-dub. It definitely shows a pretty good relationship just by lining them all up between the electrical and the mechanical events. So of course your electrical event happens first, followed by your mechanical event. The relationship between the two is every cardiac cycle, and it's all going to be shown here. We're going to go into it. Left versus right heart. Definitely you can see the differences. You have all your pressures mapped out here. Okay. He used it mainly as a teaching tool, but it's also really helpful in analyzing cardiac function, and in that it helps aid in the understanding of normal heart function, and also how different pathological conditions can affect pressures, volume, electrical activity. Can be used for interpreting hemodynamics, changes, and so forth along these Wigger diagram waveforms. Yeah. Okay. So our phases here, you have your two main phases, of course, are going to be your systole and your diastole, with everything in here being your systolic phase, everything in here being your diastolic phase. Diastolic phase composes of these four: the isovolumetric ventricular relaxation, rapid ventricular filling, slow ventricular filling, kind of where your cycle begins over here, and then the atrial contraction. Systole is going to be your isovolumetric ventricular contraction, along with your ejection phase. Okay, so I kind of blocked out, let's see, there we go. So to kind of separate it up, I just kind of blocked out the phases that we're not talking about currently. So that means we're talking about this portion here. So this one is highlighting your atrial systole. Atrial pressure increases as the atria contract. It's always going to be followed by your P wave on the EKG because your electrical activity happens before your mechanical activity. Ventricular pressure is going to slightly increase in proportion to the atria as blood from the atria enters into the ventricles. Ventricular pressure rises to a pressure greater than the atrial pressure, causing that valve to close. Okay, and this, of course, produces your first heart sound right down here, which is your lub. So this one's your EKG. This one is going to be the volume in your ventricle. Okay, so you can see as the blood is filling into the ventricle here, you're getting more volume. The blue line is your ventricular pressure. You can see it slowly increasing a little bit as the blood is emptying into the ventricle. Atrial pressure as well, because it's actually contracting after the P wave. So you get the squeeze and you get an increase in your atrial pressure there. And aortic pressure is up top here. Okay, so once those pressures reach high enough to close the valve closes. And then we go into this next phase, let me see, which is going to be right in here, this little slim line. This is the isovolumetric contraction, the start of your ventricular systole. So you can see you're right on the QRS here. Okay. The valves are all closed during this phase, so no volume is going to leave the ventricle. As you can see, the volume stays the same through this part, but the pressure is increasing because you are in contraction. You did depolarize the ventricles here. And so the pressure is increasing, but the volume stays the same, which is why it's called isovolumetric, the same volume. Okay. All right. And you can see the little side picture over here is showing where all the valves are closed. The pressures are all kind of building up here in the ventricles, but the valve isn't open yet. So no blood is leaving the ventricle yet. Okay. This section is going to be the ventricular systole. So at some point, that pressure in the ventricle right there is going to exceed the pressure in the aorta, opening the aortic valve. And this is going to give us both of our ejection phases, our rapid ejection and then our reduced ejection. So initially you get a very rapid ejection of blood, which kind of tapers off near the end of systole. The volume down here, because we're actually contracting the heart and ejecting volume out of the ventricle, so you can see the volume is dropping. Okay. The T wave down here is just the repolarization. It's going to happen at the end of systole. Okay. Then we enter into the isovolumetric relaxation phase. Again, both of all the valves are closed, so both the aortic and the mitral are shut, and the volume in the ventricle stays the same. You can see it's level here, okay? But pressure is dropping because the ventricles are relaxing through this phase, and that is also when your aortic valve closed right up here at the start of this process, which gives you the dub sound in your lub dub. Okay. And over here you can see it's depicted. The pressure is dropping in the ventricle. All valves are closed. Okay. Then we enter into the diastolic phase. This is, of course, when the ventricle pressure falls below the atrial pressure. The mitral valve will open. Atrial and ventricular pressure initially drops slightly. But as the blood enters the atria, pressure starts to rise again due to that diastolic filling, and then the next cycle starts. So this one you have the rapid filling and the reduced filling, which is kind of depicted down here, where initially you get that big dump, and then it just kind of tapers off right before you go back into the atrial contraction, and the whole cycle starts over again. Okay. All right, pressure volume loops is basically the Wigger's diagram, just depicted in loop form, with volume going this way and pressure going this way. So you can start with the different phases. You have ventricular filling down here going across, so volume's going up. Then you go into your isovolumetric contraction. This phase here, notice the volume doesn't change. It stays a straight here, but the pressure goes up because the ventricle is contracting, but none of the valves are open yet. Then you start your aortic valve opens here, rapid ejection to slow ejection, and then back into the isovolumetric relaxation phase. All the valves are mentioned in here accordingly. So mitral valve opens at the beginning of that filling phase, closes here because you don't want regurgitation to occur when the ventricle contracts. Pressure builds, aortic valve is opened once the ventricular pressure is higher than the aortic pressure, empties out, aortic valve again closes once the aortic pressure exceeds the ventricular pressure, because you don't want it to regurge. Valves keep everything going one way, then the pressure drops, and it just makes this continuous loop. So it's just volume on the x-axis and the ventricular on the y-axis. They just naturally form a loop when they're plotted out like this. You're measuring load-dependent parameters of contractility, hemodynamic changes in response to varying loading conditions. The ESPVR, or end-systolic pressure-volume relationship, that's this one right up here. This is the relationship between the pressure and the volume in the ventricle when the heart muscle reaches like its maximum state of activation near the end of systole. So
Yeah,
for
there's
any,
a lot of people that don't realize that when you go back and look at your waveform, your end diastolic pressure is not that lowest point.
it's not
It's the point just
just
before
before,
isovolumetric contraction, right?
correct.
Exactly. And that's what's so important.
I like it. And in this one, they use it on the pressure volume loops to kind of use as, I hate to use like the baseline, but it's giving the inotropy state of the heart. So as they slide up around, change different pressure variables in the system, this graph will slide up and down that ESPVR. So yeah, it kind of represents the inotropic state of the heart. The EDPVR, that's your end diastolic pressure volume relationship, and it's going to kind of represent more the compliance of the heart muscle on the lower end here. Okay, so it's kind of how you would slide up and down according to the function of that particular heart, if that makes sense.
Yeah, it does.
Okay.
I mean, I think you're making it very easy to understand,
Oh, okay, that's good.
even for me.
So this is kind of what you would be looking at to see how the loop would change in different inotropic or compliance type situations, with the blue being your normal. Infiltrated cardiomyopathy, the green one over here, it causes thickening and decreased compliance of heart muscle, basically. So it actually can have an increased inotropy or contraction. It just can't take very much preload. And so you end up, this area between here, of course, is your stroke volume is severely reduced in infiltrative cardiomyopathy, where your pressures up and down are more or less the same. You're just not getting a very good stroke volume anymore. And then, of course, dilated cardiomyopathy, the ventricle gets dilated out without any kind of compensatory thickening of the muscle. So it's just flabby. It can take all the preload. It just does not have as good of a ejection out here. You lose some of that contractility. And also down here, your volume is higher. So you end up holding volume more in every cardiac cycle than you would with a normal, and you have less stroke volume, of course. So that's kind of what these graphs are good, showing, kind of plotting out different heart conditions. I use it talking about ECMO and the backflow, and sometimes with Impella and things like that, how it can help with some of the ventricle dilating out with the ECMO and so forth. It's a good visual tool. Okay. Anybody have any questions with the cardiac cycle? I hope I'm not going too fast.
No, you're doing great.
Okay.
You're doing fantastic. This is great.
Okay. So kind of going on from
You're
there.
giving compliments too
Oh, thank you.
from Nancy. Nice way to show the different cardiomyopathies. That helps. I mean, no, this is great.
Thank you. All right. Well, moving on from there to balloon pump timing. Of course, very relevant in understanding the basics, at the very minimum, the basics of your cardiac cycle. I won't go too much into the history here, but it's the Kantorowicz brothers who brought around the first balloon pumps in the 50s. Their goal, of course, was to augment the diastolic phase, and we're going to talk a bit about that here shortly. And they did experiments with dogs and have many different models of this, ultimately ending up with the balloon pump similar to what we have today, which I won't go too much into that. Indications for balloon pump, high-risk CABG, so needing a little extra support, ventricular failure, cardiogenic shock, refractory angina, because if you're having chest pain, it's usually a perfusion problem in one of the coronaries, and that can help give you that augmented boost. Complications from a heart attack, weaning from bypass, cath lab support, especially in some more high-risk cath lab procedures. Contraindications, septic shock. So septic shock is kind of considered a condition with a high cardiac output and a low peripheral vascular resistance. And a lot of them I think something like 30% will end up with some sort of septic cardiomyopathy at some point, and in fact do end up with low cardiac outputs. Uncontrolled bleeding or coagulopathy, moderate to severe aortic regurgitation, because we just end up pushing it right back into the ventricle. Severe aortic stenosis, there's that risk of possible tearing one of the leaflets with that back pressure when the balloon inflates. Large aortic aneurysm or an aortic dissection, which is what you see here. Severe peripheral artery disease, irreversible brain damage, or end-stage disease. Okay.
I mean, two of those are really obvious. I don't know that I agree with the severe aortic stenosis, maybe the aortic insufficiency, but I'm not sure, because if you can reduce the afterload and deflation enough, would that not help the LV be able to eject?
So
Notwithstanding the valve's not opening, it's stenotic. But I mean,
yes.
do you really think it would tear the leaflets?
That's the concern, that when the balloon inflates, if it's, depending on the size of the balloon, 50 cc balloon or whatever, you're pushing back that volume very abruptly onto a valve that is not used to being compliant that way in that direction. And so there's that risk. Insufficiency, you have the opposite risk where the inflation of the balloon will push back and the valve will kind of prolapse in. And you
Or
end
you'll
up
get
with
a lot of
really,
blood in the ventricle. You'll
yes,
fill the ventricle. You'll
really bad.
exacerbate the regurgitation.
Correct.
Yeah.
So that's the deal with that. The peripheral artery disease, that of course, if it's been corrected with stent or something along those lines, it would be not as big of a concern, of course.
We used to balloon pumps used to be how we view ECMO now almost.
Yeah,
It was a big deal.
I remember that.
Big deal. We used to they would have to sew grafts on the femoral artery to insert it. There was no such thing as a percutaneous, in the early days, and it was very dramatic.
Yes.
Putting balloon pumps in was a big deal.
I remember looking through some of the Cantor's initial catheters was enormous.
And you ought to try putting them in the aorta.
Oh God.
Having them going in the transverse aorta and down.
They had one that went right through the chest wall, right
Yeah.
into the aorta, and
Yeah.
they just stitched it there.
Yeah.
That's crazy.
Yeah.
They had a lot of trouble with infection site problems there.
Yeah, I imagine so.
All right, placement. Of course, femoral approach is going to be the most traditional approach now. Off-label, you can do an axillary or even a brachial artery approach. I don't see that very often. I think I've only seen one axillary approach, but all of them that I have familiar with is going to be femoral. Balloon pumps have different radiopaque markers. Most of them just have one radiopaque marker at the very distal tip, but there are some that do have at both ends of the balloon to kind of specify exactly where it's placed in the body, different by model types and manufacturers. Correct placement of the balloon pump, 1 centimeter below the aortic knob. I'm going to have a picture here in a second. At or above the level of the carina, usually between the second and third intercostal space. Okay. And here is a good picture. So aortic knob up here, you'd want your tip somewhere in this area. Again, seen on CT here. AP window would be kind of that shadowy area where the pulmonaries kind of cross over the aorta. Carina, I can't really see it very good in here, but right about there. What do you think?
Oh, that looks good to me.
Pretty close.
Pretty close.
So it's also a pretty good landmark.
If you have a left subclavian arterial line, you can usually figure out pretty easily if you're too high or not.
Because it starts.
But you can be
get a really good waveform.
But you can definitely be way too low.
Yes.
Yeah. So yeah, it's an estimation, but you definitely don't want it too low. You're not going to have much effectiveness, and you certainly don't want it too high, especially going up the going either into the left carotid or something like that.
Correct. So yeah, somewhere in this, of course, this is the left subclavian he was talking about. If you're too far up there, you're going to really see that waveform, and too far up, and you're going to get a really superimposed, heightened balloon waveform, like a real significant whip. It can be pretty crazy looking. Too low, and you're not going to get effective augmentation. It's just too far to travel for that pressure wave. So the farther away you get from the aortic valve, the less effective your augmentation is going to be.
Clearly, yes, it makes sense.
This is just another depiction. This one I included to kind of show this little sheath up here is actually showing us that this is a subclavian approached balloon pump. The only way that you would know is if you've seen that there. This one has the 2 radiopaque markers, but it doesn't have the double radiopaque markers that some of them have that show direction that it's going. And of course, we want it to land somewhere between here and the kidneys. We don't want to occlude our renal arteries. And of course, there's your left subclavian up there. Okay. So perfusion, coronary arteries arise from the sinuses of Valsalva. That's at the aortic root. So right here, and the valve being here. Okay. They're basically anatomic dilations of the ascending aorta, which occurs right before the aortic valve. Okay. They are basically widenings between the wall of the aorta and each of the 3 cups of the aortic valve. I think we have the right and the left, and then a non-perfusing cusp that doesn't have a branch artery coming out of it, but there's 3. Okay.
Are you writing on it?
I was right there. Can
I
you see
see it. No, I see
Oh,
it.
I
Red
hadn't
and red.
hadn't
Yeah, I
written
didn't see
anything
it. I'm
too.
so sorry. I was like, am I on the? I thought we got stuck.
Okay. This part going to the left and this one going to the right. Our coronaries receive approximately 5% of our total cardiac output. Okay. Which is about 250 mils a minute, approximately. Oxygen extraction, however, from the coronaries is 70 to 80%.
Isn't that amazing that it's only 5% and the kidneys are 20?
It's crazy. It's crazy.
That's really, you really think about it, it's amazing. Because the thing has to just beat, and beat. The other one has to keep moving sodium back and forth. It's a very busy little, but they're, little beans, and here we are, whole heart.
The whole heart.
Amazing. It really is when I think about it. But the extraction
The
rate,
extraction
the kidney
is
too.
crazy.
It is.
70 to 80%. The rest of the body, typically 20-25% extraction rate. We return 75% unused back to the atrium. This 70 to 80% is why the mixed venous is so important. If you get it from the pulmonary artery, you have to know that this isn't included if you're getting it from a central line, because it does make a difference, usually about 5 to 8 on your result.
Well, as long as you're getting it if you're getting it from the right atrium, because the coronary sinus dumps into the right atrium, right? So if you're getting your SVO2 from a jugular, it's more reflective of the entire body. But if you're getting
it right in there where the venous drainage occurs.
Yes.
Yeah.
And I'm sure it depends on where in the atrium, high up, low, where it's
close.
where it's really gonna give you a good sample. But PA is gonna be, if you really want to know, if you want to include it. But when would you include it? When wouldn't you include it? When would you want to know versus not want to know?
I'm not sure I understand.
Doing your SVO2, whether you're doing a central SVO2 from the pulmonary artery, or from how you take that into consideration and how you're gonna compare it to what you're trying to assess.
I think if you're looking for body perfusion along those lines, temperature, acidosis, things that would be affecting that, probably an SCVO2 would be okay. But the SVO2 is more used in CVICU for cardiac function, so it kind of they want a very accurate number to kind of diagnose those fluctuations in regard to the inotropic support they're giving them. But
what
like
it's
with
doing
ECMO,
systemically versus what the heart is actually, its extraction is.
yeah,
You want to factor that out.
you want to factor it in. Yeah.
Is that really wise?
What do you mean?
I mean, would you not want to know?
So I consider the SVO2 somewhat of a drama child. I'm sure you've heard me talking about this before, but
No,
there's,
so I'm going to learn something here.
and I always bring this up in all of my hemodynamics classes because it is used very much so as whether or not somebody needs an inotrope or maybe can wean the inotrope down and yada yada. But there are a bazillion factors that can change your SVO2 just in minutes. You know, your patient wakes up, or, you know, maybe they're still too cold, and, you know, you're not getting what I consider a real number without perfect conditions anyway. Temperature, pain, as well as cardiac function, which really is just going to tell us if we're having stagnant hypoxia, but there's a lot of things that look like that. If your patient's going septic, your SVO2 could be 75 and everybody thinks your heart function is great, but it may not be the case. It may just be poor extraction along those lines. And so I always try to tell them, don't draw your SVO2 immediately out of the OR. Your patient is still too cold. They're still paralyzed, highly sedated. It's going to be falsely high. And maybe you do need an inotrope, but your SVO2 says different. So it's kind of like a Goldilocks. You gotta you gotta draw it when everything is good. Your patient's at a good temperature. They're waking up but not freaking out. That sort of thing.
No, that makes sense. So do you believe in it? So it's a tool, but not it's not the panacea
Correct.
of tools. So you
Correct.
need to look at the acid-base balance, lactates, and everything else.
Correct.
To get
Signs
a full,
of perfusion.
Very good. Okay.
Other signs of
Thank you.
perfusion. So, but yes. So 75% of the left main flow, 75% up here, going to the left side of your heart occurs during diastole. Okay. About 50% on the right side occurs during diastole, and the other 50% occur during systole. Pressures on the right side are much lower, so you don't have that pressure gradient that would interrupt flow or impede flow during systole that you do on the left. Okay, so this diastolic time is definitely more important for the left side of the heart. Okay. Coronary perfusion pressure is going to be the difference between the aortic diastolic pressure and the left ventricular end-diastolic pressure. Central venous pressure may be a more appropriate choice for downstream pressure to calculate the right-sided coronary perfusion. But again, the right side is not the one that we're really going to be talking about in a lot of these diagrams now, as it's lower pressure environment, and it's 50% systole and diastole, where left side is 75% during diastole. Okay. Does that all make sense? All right. This is going to be the flow in the actual coronaries themselves. In particular, left ventricular coronary flow. So you have your systolic flow here and your diastolic flow here. So it clearly shows a large increase in blood flow during diastole. These sharp decreases are occurring during isometric contraction and increases in the early part of systole. You reach systole maximum during the summit of your aortic pressure, and then it decreases significantly with the aortic pressure, and again can become negative. That's these spikes that you're seeing here. It's just the fluctuations in those pressures. Increases sharply during isovolumetric relaxation, maximum at mid-diastole, so you can kind of see right here. And then it will decrease gradually in the late diastole following the diastolic pressure gradient, kind of going down this way. Okay.
And that is primarily because when the heart is contracting and the muscle is squeezing, that essentially you're just squeezing the coronaries.
You're
gonna
putting
get
pressure on it. Yeah. Mechanical.
Externally, mechanical force. Not because the valves are in any way obstructing the coronaries themselves.
Right. Correct. Thank you. Very
Yeah,
good
no,
way to put it.
I'm asking.
No, that's absolutely
Thank
true, and it gets stretched too.
Mm-hmm.
It's different pressure gradients and things like that. But the main gist of this diagram, not only to show the blood through the coronaries, inside the coronaries themselves, not to the body, these are coronaries, but if there was a part of the cardiac cycle that you would want to take advantage of to augment flow to the coronaries, say you have a blockage in the coronaries and you wanted to improve perfusion past that blockage, you would target here. Right?
I thought you were going to ask. I was going to raise my hand
Oh,
and hopefully get the question
I'm sorry.
right.
Hold on.
Yes, that one.
What
Yes.
part would you like to target, Joe?
That one where the arrow is.
I should have waited and tested you. Okay. Of course, diastolic phase. There's just more potential here due to the lower pressures during diastole to increase the flow to them coronaries. And this was the area that the Kantrowitz brothers targeted. Okay. That is this area here. I think we went through this, but this is going through basically the Wiggers diagram. And you can just see that whole area right in here is where we're targeting with our balloon pump. I don't need to go through the whole Wiggers diagram again. We'll just move on. Okay.
Oh, that's a nice little image.
Oh, yeah, you see the, yep, there it goes. Love it. Okay, so, excuse me. Sorry.
You okay?
Yeah, I'm going to get a drink.
Somebody got a bronch?
Do not ECMO me. I'm okay.
ECMO. Get the ECMO. I know who to call to cannulate you.
Mm-mm.
I know who would.
No.
I know who would.
I know what you're thinking, and I'm going to say I refuse.
Mm-hmm.
Okay, so the balloon pump works by counterpulsation. I like to think of counterpulsation as basically two machines in one, your inflation machine and your deflation machine. I know that sounds super simplistic, but that is how it's operating. So you're wanting to increase oxygen supply to the coronaries, which reduces demand. This is going to be done through your diastolic augmentation, your inflation part of the machine. That is here. Okay, the balloon inflates and it shoots blood here, here, and down this way as well. Okay, and this happens during diastole, so those coronaries are open, everything is easily sent through, hopefully perfusing past any blockages that may be there. You are going to get that increased diastolic pressure because that's when your balloon inflates, and you're going to see this really clearly when we get to the waveforms. The inflation occurs at the closing of the aortic valve if you're timed properly, and this displaces the blood into the proximal aorta, putting a higher driving pressure behind that coronary perfusion. So it's increasing the coronary perfusion. It increases the MAP as well, just because you don't have that low diastolic pressure in the equation. So you get that significantly increased MAP. Okay, so that is your inflation part of the machine. Since systolic unloading, this is going to be kind of like the deflation part of the machine. Okay. This is going to help increase your cardiac output. Not directly like you would see with an Impella, but you do get that drop in afterload, which kind of encourages cardiac output. As kind of more like it. So 0.5 up to 1 liter per minute, up to a 30% increased ejection fraction. That being said, if you have very, very poor cardiac function, I believe less than 20% or lower, you are not going to augment cardiac output that's not there to begin with. So if you are ejecting 20 cc's, 30 cc's of blood every heartbeat, and you're trying to augment with a 50 cc balloon, you're not going to get very far. You just don't have the volume there to
Yeah,
displace.
6 mLs,
Yeah,
right? If you have a 30% ejection fraction, you get 9
there you go.
plus or minus, or less. 9 maximum,
9
right?
maximum.
Because it's 0.5 to 1, or up to 30%. Up to 30%. Right? Up to 30. So you really, yeah, it's a challenge. But I've always heard it analogized as you basically are going to push a door open, but somebody on the other side is opening it at the
pulling it.
same time.
Correct.
And when you go back to your pressure volume loops, your Wigger's diagrams and so forth, you're essentially lowering the aortic pressure because volume is leaving the area above the valve as well as other places to fill the void that was once filled by the gas balloon. And so you lower the pressure that the LV has to achieve to open the aortic valve and eject its contents.
Creating like a vacuum almost.
Yeah, almost.
Like a suction.
Yeah.
So yeah, deflation occurs during systole, causes that abrupt drop in the aortic pressure with the vacuum, for lack of a better word, created with that balloon collapse. This will lower the systolic pressure about 10 to 15%, and that helps reduce the afterload. Reduced afterload, you'll see a decrease in LV wall stress up to 20%. We know the more wall stress you have, the more oxygen you're consuming and the more demand being put on already compromised coronaries. Decrease the resistance to the LV ejection, that's your afterload, and decrease your wedge pressure with preload, due to preload. So that's the deflation part. The inflation part actually also displaces stroke volume, which kind of activates the aortic baroreceptors, kind of slowing down that vasoconstrictor reflex, and so it can actually cause peripheral resistance to decrease as well. Okay. So here's the waveform of a correct balloon pump. You have your assisted over here because the balloon does the assisting. This one actually causes confusion for people thinking that it's this one because it's closer to the balloon or whatever, but the balloon does the assisting to the beat after. So that's your assisted heartbeat there, unassisted here. This in the middle is going to be your balloon, inflated during the diastolic phase between these two heartbeats. Okay. You would use this waveform to help kind of validate that your balloon pump therapy is going as you need it to. Other clinical parameters would, of course, be the things like patient mentation, urine output, pulmonary congestion, heart rate for sure, less lactic acidosis, ST elevation should improve if you are getting more flow through the coronaries. So the balloon up here should be the highest point of your waveform. It should be, 15, 20% higher than your unassisted systolic beat. Okay. The unassisted to the assisted, you should have a drop in your systolic pressure because when the balloon deflates, it creates this little vacuum down here, and so you should be less systolic pressure after the balloon. This point here, I actually kind of consider the most important part of the waveform, and that is going to be end diastolic pressure to end diastolic pressure, or Joe uses the door analogy. I like to call this door to door waveform. This is basically, what is this, like, I don't know, 90? What do you say, 90 there?
Yeah, about 90.
So the heart has to overcome a pressure of 90 in order to eject the blood out here. That's how hard that door is to open. The balloon deflation gives this drop down here. And now this one, I don't know, what is it, like 85, 82?
Yeah, low. Yeah, it's pretty low.
That one is a less pressure for the heart to overcome in order to eject the blood out on the assisted beat, in addition to the lower pressure on your systolic. Okay. It should inflate right at the dicrotic notch, which would be here. You don't want to see it. You just want to know that that's where it would be by looking at your unassisted beat. And you can only really check the timing if you're on 1 to 2. You can't tell any of this if you are on 1 to 1 as
Agreed.
far as your timing goes.
Absolutely correct.
Okay. And you want it to make a kind of V shape. You don't want it to be a U, and you don't want to see the dicrotic notch in there. Those will be timing errors that we're going to talk about here shortly. For the deflation part, you want this one definite to be lower than the before, and you want it to be kind of a V shape. You don't want it to be a long U shape or anything like that. You want it to be a nice V because it needs to happen right before the next systolic beat. If it happens too soon, then all that negative gets washed away, and you are basically right back to where you started.
It
So
equilibrates.
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 Equilibrates. That's
That
a hard
too.
one. It becomes even again. The big words. Okay. So that's what your waveform should look like. I think I hit all the important points here. Okay. Okay. So of course, we're going to inflate at the end of systole, where the dicrotic notch would appear on the aortic, on the arterial waveform, and in the mid T wave on the EKG. And you can kind of see that here. This being the T wave, that's when it inflates. This is your balloon pressure inside the balloon itself. This is your arterial wave line. Here's your EKG. And it deflates on the R wave. Okay. So right in there. Okay. And that just shows everything lined up. All right, so variables that are going to affect the augmentation of our balloon. So how effective is our therapy doing? Again, we kind of touched on balloon position already, but closer to the aortic valve, the greater the augmentation. Too close, of course, you get that real crazy whip on it, and everybody's freaking out over your balloon waveform. Farther away from the aortic valve, the less effective or the less high your augmentation hump will be. Balloon volume, close to equal to the stroke volume is best, because then you'll capture the most of the augmentation. But it's never going to work out exactly like that. You just don't want it to be trying to augment a very low cardiac output. Balloon diameter. So if you don't want your balloon to occlude the aorta 100%, it needs to inflate to where it occludes about 85%. But of course, if it did occlude 100%, you would get very, very high augmentation. Okay. Timing of balloon pump, that's probably the most common problem when you get bad waveforms, is improperly timed or maybe erratic heart rates, such as AFib, can be very difficult to assess timing. And a lot of times you end up having to switch to like pressure mode or something like that just to get the balloon pump to function properly. Stroke volume, less than 25 mils, you're going to have very crappy augmentation. There's just nothing there to augment. Vasodilation and constriction. I've seen this for sure, where they come out and you got a very good augmentation waveform. Your balloon hump is beautiful. Patient dilates out, everything's calming down now that they have good perfusion. And then your balloon pump hump gets lower, and it's really just because it dilated out and now the balloon pump's not as occlusive. Same thing if you're having the opposite problem, you start having vasoconstriction, you may go up in the hump just because of the amount of occlusivity, how much it takes up.
Occlusivity, that too.
God!
Could you say huckleberry?
Huckleberry.
Very good. You're good. You're good.
Old dog, new tricks. Okay. Something else that could cause the same problem with this balloon pump hump may actually be this waveform, your unassisted waveform. If you start losing cardiac output, this may become more shortened, making it look like your balloon hump is higher than it was, when in fact it's just a loss of your own cardiac output. It's always a good thing to check into what's going on there, because it could actually be improperly timed balloon pump causing an increased afterload making that already injured heart work even harder, and you're starting to see loss of cardiac output. It could even be accompanied by ST elevation and so forth. Likewise, in the recovery of heart function, this hump may be going up higher, becoming more even with your augmentation hump. And a lot of the time, that's a good sign that maybe it's time to start weaning the balloon pump. I know a lot of the physicians will come in and they'll look and say, oh, it looks like we don't even need it now, because your unassisted can be matching your balloon augmentation. Okay, are you ready for your
I'm
test?
ready.
Okay. This is a aortic balloon pump waveform. What would you call that one?
Perfect.
Perfect. We're going to give this one a star and a smiley face. We have a good door-to-door. So our end diastolic before the balloon is higher than after the balloon, so we made it easier for the heart to eject blood. Okay. Dicrotic notch, we're approximately even to our dicrotic notch here, so that inflation is good. Got a really good hump here, and then our systolic pressure has been reduced after the balloon. Everything looks in good order.
Okay.
Okay.
Anybody online wants to guess, I'm not going to answer so fast, so I'll be watching. If you put a guess out there, go ahead.
Okay.
Okay. All right.
Well, this one I wrote the answer on
You
the
did.
darn
Cannot
slide.
assess. I got that one. Everybody got that one right. We did good on that one.
Everyone got that one. This one is on 1-to-1. So here's the balloon, here's the assisted, balloon assisted, balloon assisted. We've got nothing to compare it to check if we're timed appropriately. We can't compare our door to door. We can't even see a dicrotic notch on here to see if inflation's proper. That's on 1-to-1. You can't tell anything. You got to put it on 1-to-2.
I have to admit, though, it looks pretty good.
It looks pretty good.
I wouldn't be too suspicious. I'd be like, yeah, that looks good.
It looks pretty good.
Yeah, sometimes it's better to not go looking.
Not go digging too much.
Yeah, don't dig.
And please don't print the 1-to-1 strips and put them in the chart. Just print them 1-to-2. Okay. All right, here we go.
Okay, so let's see. Oh, okay. I'm going to give it a minute and let no inflation interval button. Okay, so let's see that. Okay, so let's just do this one. Somebody come up with something. I have an answer. Yes, Nancy, you are correct. I believe. Early inflation.
Yes, it is early inflation. This is where the balloon's inflating. Your dicrotic notch is way down there. We're inflating way early in the cardiac cycle. So physiologic effects of this on your patient. If we are inflating prematurely in the cardiac cycle, the aortic valve closes when pressure in the aortic exceeds pressure in the ventricle. So that means our balloon is mechanically putting pressure on that valve prematurely and closing the valve prematurely. So this could potentially increase your left ventricular end diastolic volume and hence your end diastolic pressure. You would see possibly wedge pressures increasing. You can start seeing pulmonary edema, and so forth. Also, this can increase your left ventricular wall stress because of the same thing, right? You're potentially causing some pretty good aortic regurgitation. When that ventricle wall stretches out, you're increasing the oxygen demand to that cardiac muscle, and you're swelling the ventricle, making the coronaries tight and possibly causing it a restriction to the coronary flow itself. So definitely not great. Okay, here we go.
Okay, give everybody a chance to see it. Okay. I think I know. Let's see if somebody online is going to get it. Nancy, late inflation. Okay, Nancy says late inflation. I agree with her.
Nancy is 2 for 2. Check her out. Yes, you can see the whole dicrotic notch here. Anytime you see that little M shape or anything like that in between your humps, you are most likely looking at a late inflation.
And Wongkok, I can't say that name. TIMS3, delayed inflation, same
Same
thing.
thing. Yep,
Agreed.
that's correct.
Agreed.
So, what is the physiological effects of this?
Well, I would say, I'll answer that if I may.
Mhm.
I'll say that you're basically just decreasing the amount of increased coronary perfusion that you desire. So you're decreasing your augmented diastolic pressure, diastolic time.
That is 100% correct. Joe gets a star. Yes, it's one of the less harmful timing errors, depending on how much your coronaries are depending on that perfusion pressure. But basically, if your aortic valve is already closed, and then there's that short amount of time before the balloon inflates, you have what's called aortic runoff, and the blood has already passed the balloon. So you lose the augmentation. Okay.
Yeah, that makes sense. That made sense. Okay. Okay. All right, I'll give a minute for people online to answer. I think I know. Da 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 da
Ding, ding.
da 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 da. I never had a singing career.
No,
No, but I wanted to be an actor. I did. That's what I wanted to
you
do.
could have been a singing actor.
Bad singing actor. Yeah, probably so. Probably so. Okay, I'm going to say, since somebody's answered, I'm going to call that early deflation because though it appears your end diastolic pressure is lower, but if you look at it, it dropped, but then it re-equilibrates to near baseline before it ejects.
Joe, you are on fire. That is correct. This is an early deflation. So we get the balloon deflation here, and we get this beautiful little vacuum and drop in pressure down here. But the next cardiac cycle contraction doesn't start till here. So this pressure slowly goes back, and you're almost back to where you started. So you lost a good amount of afterload reduction right there. Okay. So potential hemodynamic or physiological effects of this?
Well, let's see, Joe's sense of humor is what, oh, okay, he's trying to sing, and so thank you very much, Peter, I appreciate that. So I would say the physiologic result of that is that you are certainly increasing coronary perfusion, so you're increasing oxygen supply, but you're missing the secondary benefit, which is decreasing oxygen consumption. So you are increasing supply while not really decreasing consumption. So again, you're only benefiting, 50% of the balloon's intent.
Correct. Yes. So first and foremost, you are getting suboptimal afterload reduction. You're not getting that part of the balloon pump benefit. And even though you may not be dilating out your ventricle is still working against a higher pressure, and that's making it use more O2. Something else that can occur with this early deflation is the potential for retrograde coronary and carotid blood flow, because it goes into deflation before the next systolic phase. So you can actually steal blood with that vacuum from the coronaries and the carotids. You could actually get angina that happens because of this.
You can?
Because that balloon deflation has to take volume from somewhere on the superior side, right? It's deflating. It's gonna deflate those 40 or 50 cc's no matter what. And if you are still in the diastolic phase, you can actually steal it from the coronaries or the carotids.
Yeah, that's true. I didn't think about that. That's true. Yeah, well, that's true. I didn't even consider that.
Yep. So that is a potential risk with this timing error. Okay.
Would you agree that balloons have become ubiquitous? They're almost to the point of being like aspirin.
I do. I do.
but they're so underappreciated.
I love them.
The risk, but the damage that they can do
It
is
really
grossly underappreciated. We put them in,
really
I see
can.
it a lot. Put it in and forget it.
Hmm.
And very few people really take the time to really evaluate the balloon's effectiveness or potential iatrogenic injury
If
that
you
it's
have it
causing. Could
improperly
cause.
timed,
Yeah.
exactly, you can
Or iatrogenic
exacerbate.
morbidity, I guess would be a more appropriate term.
Exactly. Okay, here we go.
Those iatrogenic issues are bad.
They are.
And I've seen it.
I've seen
happen.
it as well, especially with the chest pain and the ST elevation. I actually seen a patient that did not have ST elevation develop ST elevation because of timing errors on the balloon pump.
Okay, I'm gonna let somebody else answer this, but I think I know what this one is. I'm pretty sure. It's an illusion. It makes you think it's perfect, but I think I know what it is.
Mm-hmm.
Let's see if
You've been
somebody's
spot
gonna-
on so far.
I think I have this.
I would
one.
bet my money on you.
Let's see, we got to get back to singing again. Da, da,
See, they
da,
like
da,
that.
da, da. Exactly. That'll just get somebody to answer because they'll want me to stop talking.
Somebody answer.
Eek. It's eek. No, it's not eek. Nope. Nope. I think he was talking about
I
my
mean,
singing.
it could
Yeah.
be.
Could be
eek.
eek. Yes.
I still think that's a fair answer.
So this is late deflation causing obstruction of LV outflow, thereby decreasing the pressure, essentially because of almost like you have aortic stenosis.
Correct. So your door-to-door or your left ventricular end diastolic to end diastolic actually goes up, meaning our balloon is making it harder for the heart to eject than before the balloon did anything. Very clearly marked here with it, the assisted beat being higher than the unassisted beat. Your inflation is good, right? Aortic dichrotic notch, your pump up. But the only thing that could cause this pressure to be higher than this pressure is an actual physical obstruction in the aorta that's actually impeding the flow. So the balloon pump is possibly impeding your left ventricular ejection, increasing the afterload. Of course, this is going to increase oxygen consumption due to the ventricle having to eject against a greater pressure. And it's definitely something that's the situation I saw when the ST elevation developed. Was a very late deflation timed balloon pump.
And can this happen both in manual and automatic?
So auto timing I have found to be very reliable in the balloon pumps nowadays, but I do still find it particularly with placement issues. Balloons that are perhaps too far in or not far enough back, you will see some timing errors that pop up that you can kind of time to help out until somebody can reposition it.
Okay. That makes
And
sense.
definitely in different arrhythmias, somebody's having a lot of PVCs, your balloon pump has to retime frequently.
Yes.
And it's easier to go in and manually time it. I've definitely seen some that were missing fiber optics weren't working properly, or for whatever reason there were other issues, and we would have to time it manually that way. And sometimes they just don't time right.
Now, the old balloons back in the early days, the Contron, I don't know if you ever saw that
I
big
did
green
not.
machine, and then the early data scopes where you actually set in milliseconds the inflation and deflation. But then the subsequent ones from there, so notwithstanding that very old technology, they were then evolved into R wave deflation. The balloon would deflate as soon as it saw an R wave, no matter what. And because of the natural electrical and mechanical delay, the theoretical purpose of that was that you could never late deflate the balloon, because we used to be able to do that very easily.
Sure.
Very easily. And because you literally set the milliseconds, and it just overrode everything. It was,
Just
you
rode
do
at
whatever
that
you wanted
millisecond,
to
yeah.
do. You could almost leave it inflated for like 3 cycles. It was very bad.
gotcha.
But that's very early on.
Yeah.
Now, of course they have that, but of course, is there individualization of the electromechanical delay? Can that vary person to person?
Probably on perhaps some of them with big bundle branch blocks or something like that that
Sure.
would spread out that whole QRS complex. If you have a very prominent T wave,
Mhm.
it can sometimes cause problems. Pacing patients,
Sure, that's
definitely
a
an
whole nother
issue.
issue,
A whole nother issue. AFib is always a problem.
because that's going to have a much shorter electrical to mechanical
Correct.
effect, and that you
Correct.
could have the late deflation problem, which is really a bad problem.
Yes.
Early inflation
It's
and
the
late
worst one.
deflation are both bad, or the two worst. With
Correct.
late deflation, you think being worst.
I do.
Mm-hmm.
But
I think it makes sense too.
sometimes you see them together, and then
Yes.
you're just like, just send him home.
Sure.
Let him go.
Or tag his toe.
Something,
Yeah, we
right?
just
We're
put a tag on,
double
yeah,
whammy,
or
but
her.
those definitely are the worst too.
I thought the late deflate was dangerous, but I have now learned that early deflate causes retrograde flow, steal from corner. Yes,
Mhm.
that is true, Nancy, and I think that's in fact, it intuitively makes sense, but it wasn't until she said it that I was like, yeah, that's true. So yeah, absolutely. Okay.
Yep.
Let's see if I could get 100% today. I'm hoping.
Okay. So now we definitely can have timing errors, both inflation and deflation side, which is how I normally find them. But here we go.
Okay. Okay, well, I know what's wrong here.
Okay.
I have this one, I believe.
You got it.
I'm trying to shoot 100. I'm trying to get 100% today.
So far, you are on fire.
Anyone online? Da, 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 da. Early inflation and early deflation. Okay, I would say I'm going to disagree with that.
I'm going to say 50% for that one.
I'm gonna say late deflation, which is maybe what you meant. Late inflation, early deflation is what I believe.
Yep. You got it, Joe.
I got. Okay, good.
So you
So
have
Nancy, I got 100 on that one. I got a full credit
got late inflation here. You
because
can
you
see
can
the
see the
dichrotic
dichrotic
notch.
notch.
So you don't have very good augmentation. Your hump's kind of muted.
She retyped it. She meant late. I know you really
Okay.
did.
She's been getting them.
She
so,
gets 100. She gets credit, full credit.
She's
'cause
had them all so far.
that was just a mistake.
okay.
Delay
And
inflation
then early
and
deflation
early deflation.
over
Delay
here.
Yes, and so did Timsry.
So yeah, we're not getting why does this patient even have a balloon pump? We're not getting the inflation benefit or the deflation benefit.
Well, would you say none? Would you really say none?
I mean, we
I mean, there-
potentially could be stealing from the coronaries here.
Well, that's true.
So we could
That's
actually be doing
true.
harm with no benefits.
That's true too. Okay, yes, I would agree with that. Yes, okay. But predicated on that new obvious revelation, which should have just intuitively understood. Yeah, you are correct, because I would have argued that diastolic pressure increase time would at least be of some benefit, but you're saying it's negated by the steel.
Yeah.
So you're not really getting a benefit. You're getting, and you could actually be getting disadvantage versus just no real total benefit.
Correct.
Okay, fair enough.
So why bother
That
even
makes
having
sense.
it? And then this one is the Mac Daddy of bad timing errors here. If you
Okay.
see this waveform, it's pretty obviously when you see it that it is not right. And I always feel like it's flipping me off a little bit, actually.
Yes, that one's. I'm going to let somebody online answer that one. I think everybody's done really well.
Yeah, for sure.
Flipping you off. Yes, Nancy, it is flipping. Oh, I see what you're saying.
I feel like it is always flipping
yes,
me off, right?
I think it is. I think it is.
Not in the CVP waveform with the really high pulmonary pressures.
Oh, God, yes.
It's always flipping me off. I just know I'm screwed as soon as I walk in the room. This is going to be a bad shift, you know?
Let's see if anybody's going to get this. Early inflate, late deflate. Agreed, Nancy, agree.
100%. So yeah, you are prematurely closing the aortic valve because it's supposed to close down here. So you're stacking blood into the ventricle, and then you're making it harder for the ventricle to contract to get rid of it. It's a double whammy. By all means, call somebody, phone a friend, help this guy. Fix the timing if you're able. I have physicians, you know, a lot of the hospitals want us to keep it on auto now, but if I see a timing error like this, I will put it on 1 to 3, and I will call the physician and ask if he wants me to retime it, and they always say yes,
Yes.
please do.
Yeah.
Because this is a dangerous waveform.
Yes, I would retime it first. And I know you do, but I know that you have to say online.
I have to
I
say,
know you have
I
to
called
say,
the physician.
Yes, yes.
I would never just do it and then send a message saying this
Right.
is what I did.
Nursing board, you heard that, right? She would never, ever. Exactly.
Correct.
And Timsry also got early inflation. Yes, that was almost really very obvious.
And then the reason to put it on 1 to 3, you're just doing the damage every third beat instead of every single beat.
And decrease the volume to 50%.
Yes.
Or 30 or 20.
Yes.
Put it on flutter.
Put it
Do
on-
something. Stop.
We can't unplug it. That's not good either. But
It'll
yes,
run on
we can put
battery
it on
long enough,
flutter.
but we could flutter it. Yes, we
We
could
can-
do something.
Flutter it.
Mm-hmm.
Just kind of slow down how often it's doing the damage.
Mm-hmm. Okay.
Well, very good.
Is that it?
That's it.
That was.
I went
your
through it a lot
references?
faster than I
You did great.
normally do.
Well,
but I was
we're
trying
we're
to.
perfusionists, and we don't have any attention span. You know,
Yes.
everything. You know, think about it. You know, we're out. Our mantra is out by noon with no balloons. Okay, so when we go in and do a case at 7 a.m, it's like we want out by noon with no balloons, so we can go do what we play and do what we
like
want to do,
that.
right? And that's what we do. So with all of that said, Joe, you and I think alike. Exactly. Thank you. That's scary, Nancy. That's frightening, actually, if you really think about it. But excellent work. Excellent.
Thank you.
That was really good. I mentioned in the comments, I don't know if Magic could put that up, that we will be releasing an ICU, a CVICU essentials course very soon that has IABP included
Oh, and
in
that
it.
one is very
And-
in depth. I go into the DPTI, all of that one in that video. That one is very intense.
Yes, it is. And that's going to be coming very soon. So look for those announcements. Vicki, thank you so much. Well done. Lots of reminders I have misplaced in my mind. Excellent. Well, I'm glad. And you know, everyone, thank you so much for your participation too. You're what makes doing these fun. And I think for those of you who will be with us tomorrow morning, let me see our patient. This is our patient. We'll have several of them, and we will be doing a game whereby we'll be asking actual board questions, and everyone will have their own little. Just dropped that.
I would call this COPD patient. by his
COPD
face.
patient.
Look
Yes,
at his face.
he is a little blue. He looks like a blue. He
He's
looks
a
like a puffer.
COPD patient.
And they'll have their own little dry eraser board. They'll write the answer down, and then the answer will be revealed. And those who got it wrong will have to roll the die, and that die will give them a number, and they will have to insert these deeper and deeper until the patient explodes. And if the patient explodes on you, then you get a point. Highest point loses. and the game is played where it's 1 point for the first round, 5 points for the second round, 10 points for the third round, and then one final question worth 50 points. So even if you did poorly, you could still maybe come out the winner. And it's intended to be a lot of fun, and that's going to be tomorrow from 5 a.m. until 8 in the morning. And then I think I have a lecture after that I'm going to do for Bruce on what is going to be, what does perfusion look like in the next 20 years?
Yeah.
That's going to be more of a conversation-based thing. I think Samir Patel is going to be joining us
Nice.
with that as well. I think that's going to be important for a lot of, especially our younger colleagues.
Oh, yeah.
You know, I've been in this industry now 46 years. The industry has been around since, you know, it's going on like its 75th year, somewhere around there, right?
Yeah.
So you have the first successful use was in 1953. Perfusion became an actual profession somewhere in the early 70s,
70s,
right?
yeah.
And so that's 50 years, some 55, 60 years, something like that. So, you know, I've been in it a long time, and I think that, you know, people want to know, is this going to endure? You know, a lot
think
is
so.
changing right now, and I mean, we all have perspectives, and I'll be interested to see what how this all turns out. You know, it'll be a discussion for tomorrow. But with that said, and then I have to go do a heart. So we got a lot to do tomorrow, and but we're going to get it done, and we're going to have a lot of fun with it. But thank you, this was excellent. Good,
Thank you.
great work as usual.
Thank you.
Okay, we'll see you all tomorrow morning. Those of you who are here, I will be there for tomorrow's stream. Sounds like it is going to be fun. And you're going to even get to participate, Peter, if you want to. Also, Joe, I know it didn't have anything to do with the stream, but thank you for talking about perfusion simulation with me. No problem at all. I'm happy to do. Like I said, we have an incredible look. Vicki is the director of our ECMO program. She is our director of the ECMO specialist program. She is the director of the ECMO training program for adult ECMO specialists. The program that she put together is approved for ABCP credits. It's approved for CME, for physicians and mid-levels. It's approved for credits for nurses. And it is accepted, not endorsed by, and it's very important. We have to be very careful with our language because ELSO is very, very strict about this, and I want to respect them because they're an incredibly good organization. However, the content and the accreditations that our program has, they accept for your eligibility to be able to take their adult ECMO certification exam. And the course that Vicki has put together, along with the simulation that goes with that, is accepted by them, and it is extremely comprehensive, very intense. I'm extremely proud of her for what she put together, and we're doing those right now at limited numbers throughout the year, but intend and plan on making that more of a routine thing. And Vicki has the ability to not just do it here, but all the didactic is virtual. That's a lot of the reason why we're creating this studio, but we're also going to be able to bring it. The simulation all has to be in person. But I think we may
Definitely.
be able to figure out some way to do these kinds of simulations
For sure.
virtually as well. I think it's possible, a little more challenging, but I think we can do that. We're going to try. You know what? We're going to try. It's never the same, and I realize that, but
Yeah.
sometimes you have to sort of think outside our proverbial silo and figure out how to make something work versus, you know, it won't work. It may not be perfect, but we got to make it work, I think, for some people. But our simulations with the new studio and our association with Memorial Hermann, the Woodlands, has worked out really, really well. But she can also
Fantastic.
package it all up and bring it to you if you have a unit that wants that kind of training. I mean, it's really
Yes.
incredible at what we can do. So, and you've created it, you've done it. And Vicki is, she's very much a behind the scenes kind of person. She doesn't like being in front of cameras. She actually despises it. but she's getting better and better at it. It's almost as if she's been given a life sentence and she just may as well go ahead and without the possibility of parole. So she may as well just start liking the prison cell that she's in, because you've done really well with it.
Paint some flowers on the wall or
You know,
something. In this.
look, all y'all have to do is just put some money on her commissary and she'll be happy with it. Okay. We'll see you all tomorrow morning. Peace.